Hello, ladies and gentlemen. I'm Jordi Merchan Bravo. I am a medicine student of the Catholic University of Santiago de Guayaquil, and today I will talk to you about primary hyperoxaluria. Primary hyperoxaluria is a rare inherited condition resulting in increased excretion of oxalate, with oxalate stones being common. Applications in medicine, pathology. The buildup of oxalate in the body causes increased renal excretion of oxalate, hyperoxaluria, which in turn results in renal and bladder stones. Stones cause urinary obstruction, often with severe and acute pain, urinary tract infection, and eventually kidney damage.
Hello everyone, Dr. Mungli here. Today I'm going to explain you on hyperoxaluria. In particularly, I will be explaining you primary hyperoxaluria. Hyperoxaluria basically it means excess levels of oxalates that are found in the urine, and this is generally because of consumption of dietary sources which are rich in oxalates. Generally, the green leafy vegetables are rich in oxalates, and also the green tea. Excess consumption of green tea is known to cause excess oxalate excretion in the urine, giving rise to hyperoxaluria. So, in today's video, I am primarily explaining primary hyperoxaluria. Primary hyperoxaluria it differs from just hyperoxaluria. So hyperoxaluria is generally because of it is secondary to consumption of excess oxalate containing food source, whereas primary hyperoxaluria is because of inherited condition. It is because of autosomal recessive inheritance of or defect in a gene that is coding for some of the enzymes which are involved in metabolism of glycine. So note that primary hyperoxaluria is because of defect in a metabolic enzyme involved in glycine catabolism. So glycine undergoes deamination process by an enzyme called glycine oxidase enzyme. So the glycine here, so I am starting from the right lower corner here. Glycine, amino acid glycine is oxidized, means there will be deoxidative deamination of glycine into glyoxylate. This will be done by glycine oxidase enzyme. So there will be ammonium ion released. Glyoxylate is converted to glycolate, and this will be done by enzyme called glycolate reductase enzyme. All these reactions will be going on in the cytoplasm. So glyoxylate is converted to glycolate by glycolate reductase enzyme, and previous to that glycine is converted to glyoxylate by glycine oxidase. These reactions will be going on in the cytoplasm. Once glycolate is synthesized, so glycolate will be transported into peroxisome. So further catabolism of glycolate will be going on in the peroxisome. So the glycolate is reduced back into glyoxylate there by glycolate oxidase enzyme, and glyoxylate now it will undergo transamination reaction where the amino group donor is alanine. So generally amino group donors in transamination reactions are glutamate to alpha ketoglutarate. Now alanine is acting as a amino group donor here. So the glyoxylate will be converted to glycine in this reaction, and alanine it will be converted to pyruvate. And this reaction it will be catalyzed by enzyme called alanine glyoxylate transaminase, which is also called as glycine transaminase. As with any other transaminases, so this transaminase also needs vitamin B6 in the form of pyridoxal phosphate. So this is one of the important reactions that we need to understand here to understand primary hyperoxaluria. So it's because In primary hyperoxaluria, there will be a defect or deficiency in alanine glyoxylate transaminase, which is sometimes written as AGT, that is alanine glyoxylate transaminase, which is simply referred as glycine transaminase. So, if there is a defect in alanine glyoxylate transaminase or glycine transaminase, that will decrease conversion of glyoxylate into glycine. So that will lead to elevation of glyoxylate in the peroxisome, and now the glyoxylate will leak out into the cytoplasm. So whenever glyoxylate is elevated, it will be leaked out into cytoplasm from peroxisome, and the cytoplasmic glyoxylate level increases. Now glyoxylate, it will be diverted into oxalate formation. This will be done by lactate dehydrogenase enzyme. Now that's one of the major fate of glyoxylate in the cytoplasm. Another fate of glyoxylate in the cytoplasm is glyoxylate can be converted to glycolate, but as we have just now seen, glycolate moves into peroxisome, and then in the peroxisome it is converted to glyoxylate, but glyoxylate cannot be converted into glycine because there is a deficiency of glycine transaminase. Again glyoxylate, it will come back into the cytoplasm, levels of glyoxylate in the cytoplasm is increased, and that will go towards oxalate formation. So the oxalate, now it will be excreted by our renal tubular cells into urine. So oxalate levels in the urine increases, and this is when oxalate, it will combine with calcium molecule in the urine, giving rise to calcium oxalate stones or calcium oxalate crystals or precipitates. So this calcium oxalate precipitation can give rise to formation of stones in the urinary system, which we call it as urolithiasis. So stone formation can be seen in the renal tubular cells or renal tissue called nephrolithiasis, or calcium oxalate stones can be seen in the urinary bladder. So because of the stone formation, so this will slowly decrease the glomerular filtration rate, and ultimately patient will progress into renal failure. So this is one of the complication with calcium oxalate stone formation, which is seen in primary hyperoxaluria. And there are three types of primary hyperoxaluria: type 1, type 2 and type 3. Type 1 primary hyperoxaluria is the most common one, and that is because of defect or deficiency in alanine glyoxylate transaminase, which is also called as glycine transaminase. So in glycine transaminase deficiency, or calcium oxalate increases, that will give rise to urolithiasis, nephrolithiasis, stones in
Type 1. Signs and symptoms of PH1 vary in severity and may begin anytime from infancy to early adulthood. Symptoms may include recurrent kidney stones, blood in the urine, and urinary tract infections. Living untreated, PH1 can result in end-stage renal disease, which is life-threatening. Type 2. Primary hyperoxaluria type 2 is a rare condition characterized by the overproduction of a substance called oxalate, also called oxalic acid. In the kidney, the excess of oxalate combines with calcium to form calcium oxalate, a hard compound that is the main component of kidney stones. Deposits of calcium oxalate can lead to kidney damage, kidney failure, and injuries to other organs. Pros and cons. Pros. Primary hyperoxaluria has no advantage as it is an hereditary metabolic disorder. Cons. Excessive oxalate production. This case can be easily diagnosed in patients. Three types of molecular disorders.
Hyperoxaluria, an hereditary disorder that causes a special type of stone to form in the kidney and the urine beginning in childhood, also known as oxalosis. The clinical features of this disease include the following: urinary tract stones in the urine and kidney that are composed of calcium oxalate and lead to kidney failure; cardiovascular, heart block, insufficiency with spasm and even blockage of arteries; skin, livedo reticularis, marble-like modeling and acrocyanosis, blueness of the fingers and toes; skeleton, pathologic fractures, bone breaks with minimal, if any, trauma; eyes, optic neuropathy, optic nerve disease. A key laboratory finding is deficiency of an enzyme called peroxisomalanin glyoxylate aminotransferase, the biochemical basis of this disease. Another key lab finding is continuous high urinary excretion of oxalate. Inheritance of the disease is autosomal recessive with two separate loci. This means that the genes for this disease are on autosomes, non-sex chromosomes, and that parents carry one copy of such a gene, and that the chance for each of their children to receive both of their genes and have the disease is 1 in 425%. By two loci is meant that there are two genes at different spots in the human genome that are capable of causing this disease. Mutations at these two spots perturb the molecular system of
Issue applies in Ecuador. In Ecuador, hepatic transplants are performing as a therapeutic indication. This is also considered as a rare disease requiring care in our country. Conclusion: primary hyperoxaluria is an hereditary disease, autosomal recessive metabolism in some cases, and whose therapeutic indication will be hepatic transplantation, but it's not completely verified that it improves the quality of life of the patient.
Hello everyone. So today I am here to talk about the primary hyperoxalosis and hyperoxaluria. So I just go through what is the definition or how does primary hyperoxalosis and hyperoxaluria will occur. So as we know, the hyperoxalosis can be of two types. So it can be either primary or the secondary. If it is a inborn error of metabolism, then it is considered as primary. So primary hyperoxaluria is one of the inborn error of glyoxylate metabolism, and it is a recessive autosomal inherited condition. There are mainly of three types. So first one, that is a primary hyperoxaluria 1, which comprises the 80% of total primary hyperoxaluria, and that occurs due to deficiency of alanine glyoxylate aminotransferase. The second type, that is PH2, which comprises 15% of total primary hyperoxaluria, and that is due to deficiency of glyoxylate reductase and hydroxypyruvate reductase deficiency. So this was first was about the deficiency of AGXT, second is about deficiency of GRHPR, and a very rare variant, that is a primary hyperoxaluria type 3, which is consist of around 5% of total primary hyperoxaluria, and which occurs due to the deficiency of this HOGA, that is hydroxyoxyglutarate aminotransferase. So these are different types which leads to primary hyperoxaluria, and that leads to accumulation of oxalate in the system, and that is known as the systemic calcium oxalosis. So again, just revising and summarizing the different causes for the primary hyperoxaluria. The most common cause that is a deficiency of enzyme AGXT, which is present in liver peroxisome. Another one, that is type 2, which is a deficiency of GRHPR deficiency, and type 3, that is a rare variant, and that is due to deficiency of HOGA1. So these are the different types of primary hyperoxaluria. And pH1, the incidence rate is around 1 per 1,20,000 live births, and it's a deficiency of alanine glyoxylate aminotransferase. So now what does happen in case of primary hyperoxaluria? So normally what happens, the glyoxylate, which is formed by different metabolism, will be converted to glycine with the help of AGXT, and some amount will be converted to glycolate, and some amount will be converted to oxalate, and these glycolate and oxalate will be excreted in the urine. So most of the amount of the glyoxylate will be converted to the glycine in the peroxisome of the liver with the help of AGXT. So there is in case of primary hyperoxaluria, this enzyme is deficient. So this pathway is blocked. So now the glyoxylate will try to take the alternate pathways. So glyoxylate will be more converted to glycolate, which will be appearing in the urine, and more amount will be converted to oxalate. Again, this will enter into the urine. But once the kidney is saturated and it cannot excrete the much amount of oxalate, it starts to accumulate in the plasma, and ultimately it will start as the calcium oxalate in skeleton of the body. So that was all about.
Thank you everybody for your attention.